this WHA 77 ecosystem event on advancing kidney care for all. My name's Richard Jones. I'm editorial director at Devex, and it's a real honor to be here in Geneva, here at the Intercontinental, with such an esteemed group of experts and advocates on chronic kidney care. I'd like to thank our co-hosts, the International Society of Nephrology, ISN, as well as acknowledge the support of our event partners, AstraZeneca, Boehringer Ingelheim and Lilly, and Novartis. And also a big thank you to you, our in-person audience here in Geneva, and of course for everyone watching along online around the world. Welcome. Now, chronic kidney disease, often termed the most neglected chronic disease, presents a truly devastating global health challenge, especially in low and middle income country contexts. There's at least 5 million lives at risk annually due to lack of access to critical treatments. The urgency to address this issue really can't be overstated. By 2040, kidney disease is predicted to rank as the 5th leading cause of death worldwide. The disease affects various aspects of health and society, and it's really exacerbated by poverty and other diseases like diabetes and cancer. While recent advancements offer hope for prevention and improved management, barriers persist, including limited awareness, high costs, inadequate medication access in community settings, and poor adherence to treatment guidelines, even in affluent nations. So today, what are we going to do? We're going to explore the strategies needed to improve kidney health, emphasizing early diagnosis, holistic care, and expanding access to life-saving medications. But before we dive into our discussions, let's hear first directly from a number of people with lived experience of kidney disease. So at this point, I'd like to ask our producers to cue a short video to help us set the scene.
Y siempre entendí que la diálisis era simplemente, como si se pudiera decir simplemente, ¿no? Pero que era un estadio intermedio a lo que era la curación, que era obviamente el trasplante.
Y ahora, bueno, con el trasplante de riñón no estoy bien, nada más que tengo que cuidarme todavía, nada más que eso. Y me sentí contento, feliz, porque, bueno, tenía suerte, porque me contaron que yo tenía 40 personas delante mío, y al recibir la donación me sentí bien contento.
Saber yo que en algún momento me tenía que hemodializar y me tuve que mudar de la localidad donde residía a otra localidad. Eso conlleva que tenés que abandonar tus afectos, tu trabajo, te complica la vida, si no tenés una situación económica más o menos estable, los costos que a veces eso conlleva, lo tiene que afrontar el paciente.
Both the doctor and the patient needs to have a very fair playing field where they're able to talk to each other, address their concerns, and the future of that relationship, which is the better outcome of healthcare for the patient.
Las cosas pueden terminar bien y se puede remitir con los cuidados, haciéndole caso al médico, a todos los médicos, tomando la medicación como corresponde y, bueno, nada, de dejarse acompañar por todos, dejarse ayudar.
Many thanks to our contributors there for sharing their stories. I'd now like to welcome to the stage Devex Associate Director and Partnerships Lead, Ali Blunt, together with our first guest, Dr. Valerie Lakes, Chair of the ISN Working Group, and Daniel Gallego, President of the European Kidney Patients Federation. A big round of applause for our first guests.
For that introduction. It's great to get today's event started with those incredibly important patient perspectives. Thank you, Dr. Valerie and Daniel, for being here. Now, we know that there's a real lack of awareness around CKD, especially at the primary care level, which often means a lack of diagnosis. So I want to start by talking about this lack of awareness. And Daniel, as someone who has received dialysis since 1995, you've long advocated that CKD is not adequately recognized as a major public health issue. What specific steps can we take to raise awareness about CKD and the risk factors?
Well, good morning, everyone, and many thanks for ISN and Devex for the invitation. I think the first thing is important to have the patient experience, the patient voice on the stage. I think all the conferences, all the scientific events need to have a patient, because I'm usually saying that professionals are giving the news and patients are giving you the truth. So the truth needs to be heard, and usually the truth only hurts once. So I'm gonna share with you the truth. The truth is that the chronic kidney disease have been the most neglected disease during the last decades, and we need to. I think the key to empower people is education. It's not only information. So we need to implement education programs in universities, in college, and awareness in primary care, professionals, patients, to educate themselves, like to manage the symptoms, to detect the symptoms in time. And of course, I think with the awareness, we need to replicate the strategies like cardiovascular diseases or cancer during the last decades. We need to put in the TV and all the media and that the chronic kidney disease is a major public health problem. And of course, with this education, I think we need to change the landscape of CKD in the next decades. Of course, awareness is a question, a collaborative effort of everyone: governments, decision makers, politicians, patients, in pharmaceutical industry, professionals, everyone. We need to collaborate and just to eradicate the kidney replacement therapies in the second part of the 21st century. Until today, for me, the best kidney replacement therapy is do not need kidney replacement therapy. So delay the progression, manage the progression, or even restore the progression with the new therapeutical options.
Yeah, thanks, Daniel. And given the large proportions of people with hypertension and diabetes that are unaware of their diagnoses or inadequately treated, how significant is the impact of those conditions on the global burden, and what needs to happen here in terms of better awareness raising? I'll maybe turn it over to you, Dr. Valerie.
Yeah, so I think hypertension and diabetes are actually the leading causes of kidney disease around the world. There are in different places different causes, and there are certain hotspots, like we were discussing yesterday in Latin America. There's specific hotspots of other causes of chronic kidney disease. But I think, almost for simplicity of messaging, these two, diabetes and hypertension, are the leading causes, together with increased body mass index. And these things are all detectable at primary care level and can all be detected very early with relatively simple means. And if we at least identify people with these risk factors and manage these risk factors properly, we might even be able to protect the kidney function in those people and prevent these people from developing chronic kidney disease, because chronic kidney disease is a consequence often of these diseases left uncontrolled for too long. So I think we know that about half of people with hypertension are not diagnosed. And amongst those who are treated, only 20% are treated, or only 20% of all hypertensives are treated to target, meaning that their blood pressures are well controlled. And then about 60% of people with diabetes are actually diagnosed. So there are big chunks of people with these risk factors still not diagnosed. And that's an opportunity to identify these people, and then within those people understand that they have risks for kidney disease, and then obviously screen and try to identify people with early kidney disease and treat as early as possible. And we now actually have extremely effective medication. So I think we definitely have no excuse to try to identify everybody who could benefit from these latest tools that we have to protect kidney health.
Thanks, Dr. Valerie. And we'll get into a little bit later some of those risk factors, and we'll talk a little bit about treatments. We'll talk about early detection first, though, which you've touched on. And Daniel, I read an article that you published recently highlighting the importance of early detection and prevention of CKD. What strategies do you believe are most effective in early diagnosis, particularly in those low resource settings?
Yeah, of course. I think for no health policy is truly complete without prevention and early detection. So the story and the chronic kidney disease is the history of successful deny. The successful of the kidney replacement therapies have denied the strategies of prevention and early detection. So we need to change the strategies in the landscape. It's quite clear, no? We are growing and growing the number of patients. I think, of course, the effective strategies we need to deploy in among the diabetes, hypertension, obesity, and genetic diseases, no? I think one example of early detection is to introduce in the primary care the profile, the kidney patient profile, ABCDE. I mean, ABCDE is A is albuminuria, B is blood pressure, C is cholesterol, D is diabetes, and E is estimated glomerular filtration. This is not expensive. It's a lab test, and blood pressure is just taking the measure. And we need to introduce this in primary care and to try to detect chronic kidney disease early, because a delayed diagnosis is always compromise life expectancy and compromise quality of life.
Yeah, and Dr. Valerie, anything you'd add to that in terms of some of the opportunities that we're missing for early detection and treatment, especially given some of the risk factors that you've both mentioned, high blood pressure, high BMI, for example?
So I think the opportunities actually that are being missed are quite different in high and low income settings. I think in high income settings, a lot of the time, even patients are not aware that they should go to their clinicians, their primary care doctors, and ask, what about my kidney health, for example? In low income settings, some of the big barriers are that even the basics to screen are not available. So even a simple urine dipstick test is not available in all the primary care settings in low income settings. Most places, because the ISN has done a survey, and they've published that in the Global Kidney Health Atlas, and everywhere has a blood pressure machine, for example, and a scale to measure somebody's weight. So those two things should definitely be diagnosed. But to be able to check blood sugar, to look at the urine, and a blood test for kidney test is even more difficult to get hold of. So in lots of low and middle income settings where we know that there are a lot of risk factors for chronic kidney disease, there is basically the primary care physicians don't even have the opportunity to make the diagnosis. Plus, at sometimes the primary care physicians or primary care health workers are not actually educated that kidney disease is something important in their community that they should actually be looking for. And then, as Daniel said, sometimes people think, well, we don't have dialysis, so why should we even try to diagnose kidney disease? And that's another big problem, this sort of nihilism that dialysis and transplant are the only treatments. That's really the end of the road when we've actually missed all the opportunities beforehand to try to prevent kidney disease.
Yeah, and Daniel, I know you've been pretty critical about the limitations and psychosocial impacts as well of current treatments like dialysis. What are some of the most critical innovations that we need to improve treatments and improve quality of life for those that are receiving care?
Yeah, absolutely. All the kidney replacement therapies available today are far from adequate. It is impossible to conciliate dialysis at center. The 80% of patients are dialysis at center 3 times per week. The model is completely obsolete with a huge restriction, unbearable limitations. So I think we need to address the humanistic burden of chronic kidney disease. Beyond the clinical burden and beyond the economic burden, there is a humanistic burden. I mean, the humanistic burden of chronic kidney disease is health-related with quality of life, daily life activities, life participation, and of course, care partners and caregiver healthcare related to the quality of life, because chronic kidney disease is a family issue. The family is adapting the menus, the agenda, everything, medication. So we need to incorporate this vision, holistic vision, and of course the innovation is not only possible, it's imperative, because we need something real portable, tiny machines, bioartificial kidneys in the future, the regeneration of the dialysis flow without water plants for low-income countries, and we'll see. No, we are expecting that in the incoming years we will have this innovation and change the opportunities, because millions of people are dying because they don't have access to dialysis in the world. So we need to change that in the kidney community and society in general. It's a social responsibility that we need to do something, especially in the high-income countries.
Yeah, painting a pretty bleak picture here in terms of the lack of care, lack of awareness. So maybe, Dr. Valerie, a bit of a bright spot. You can highlight some of the promising breakthroughs in treatment and how can we ensure that those become available in low and middle income countries?
Yeah, so I think just even the basics, we know that if you manage diabetes properly and you manage hypertension properly, you help people to live healthy lifestyles, reduce smoking, exercise, make better food choices and things like that. All of those things are actually protective for kidney health. We also know, for example, that kidney disease is a major risk factor for cardiovascular disease. So if we can prevent kidney disease, we're also going to positively impact the huge cardiovascular burden in the world. So that's another positive reason why to pay attention to kidney health. And then if people do have kidney disease, which is a reduced glomerular filtration rate, which is the sort of rate at which the kidneys clean the blood, basically, or they leak protein in their urine, we now actually have very effective medications. There are certain medications called the renin-angiotensin system inhibitors that have been around since the mid-80s, and we know that those have saved lives. They also have a very positive impact on cardiac function, and they prevent the rate of deterioration of kidney function. But now we actually have certain medications that have been developed in the diabetes world to treat diabetes, called the sodium glucose cotransporter inhibitors, and then there are other inhibited GLP-1 agonists, etc. So a little and also there's mineralocorticoid receptor antagonists. So 3 new sort of classes of medication that have actually been studied in the last couple of years. They dramatically reduce mortality, they reduce cardiac complications, but also extremely importantly, reduce the rate at which kidney function is lost and the need for dialysis. So we're really hoping that these drugs, which should be accessible to everybody, because dialysis might be difficult. You need a lot of infrastructure, but to get a tablet to somebody that is affordable it seems like a problem that should not exist. It should be available to everybody. And so we are basically pleading from the kidney side that everyone around the world should have access to diagnosis so that when they need these medications and they're indicated, these medications are then available, affordable, sustainably, continuously available. And these medications should really very positively impact the kidney disease burden, but also the cardiovascular disease burden, and improve, obviously, control of diabetes as well for the future. So there is a lot of hope from our perspective. The huge question is how to get these medications to the people who need them everywhere, because the markups are enormous. The prices go from a few cents in India to hundreds of dollars a month in America. And in between, the prices vary for the same drugs.
Yeah, and just a follow-on question to that, say that we somehow tackle this issue of availability and access. How do we then effectively engage communities? And because it's about people, right, and it's about patients. How do we effectively engage communities in these low-income settings to support kidney health initiatives, whether it's the patient, the doctor, their family? I'll pose it to both of you. Maybe start with you to kick us off, Daniel, on that one.
Now, of course, I think civil society and of course community is very important, from the universities, from the agreements with institutions to collaborate with professionals and societies. I think kidney disease is a society public health problem, and we need to involve as much as possible everyone. So in the future, I hope that we can collaborate together with all the people here. I see from the industry, from the professionals, from the ISN, and all together because the kidney replacement therapies are out-of-pocket treatments. So we need to diagnose better and diagnose early, just to avoid the kidney replacement therapy that is out-of-pocket treatments. So, of course, with these drugs available for everyone, hopefully in the future for diabetics and non-diabetics, with reduce the obesity, reduce the cardiovascular disease is the first cause of mortality, even in the kidney transplantation is the cardiovascular disease or in dialysis patient. I think the life expectancy in dialysis is less than the general population everywhere, even in the high-income country. So I think we need to change this landscape, and it's a matter of everyone here in the community.
Dr. Valerie, anything you'd add to that?
Yeah, I think building this trust in the community that kidney disease is treatable. Because, for example, I came across colleagues in Nigeria who basically said, yes, almost everybody knows somebody who's died of kidney disease in certain places, and they basically don't want to know their diagnosis because they think there's no treatment. So I think we need to remind people now that there are treatments. But I think as well, even in high income settings, the adherence to the medication, there have been certain studies that around 30% of patients say they don't always take their medication, etc. So I think we need to develop this dialogue, as came up in one of these videos, that it's a team between the physicians and the patients. We're on the same team. We're not on the other side. And we really work together to try to figure out in a specific patient, what does that particular patient need? What does that particular patient understand? Have we explained in a way that the person actually understands? So that we really develop this therapeutic alliance to build kidney health and just remind people, you can live a very healthy, long life if one is careful about lifestyle and has good access to treatment. So I think the biggest thing for us is also just this idea to build this therapeutic alliance that then is a strong alliance and really protects kidney health going forward.
Yeah, thank you both. And some really great final calls to action there, especially around a collaborative approach across stakeholders, many of whom I know are in the room. I'm afraid we're out of time, but you've teed us up really well for our panel. So pleasure having you both. Thank you so much. And I'll turn it back over to Richard.
Thank you.
Many thanks, Ali, and to our first guest, Dr. Valerie and Daniel, there for helping us set the scene so eloquently. I'd now like to invite to the stage my colleague, Jenny Lee Ravello, senior reporter at Devex, who many of you will know from her weekly checkup reporting. And if you haven't signed up to that yet, you really must do. Joining her on stage are our three distinguished panelists, Dr. Bianca Hemmingsen, Medical Officer Management of NCDs at the World Health Organization, if you'd like to join Jenny on the stage, Dr. Anna Stavdal, Immediate Past President at the World Organization of Family Doctors, and Alison Cox, Policy and Advocacy Director at the NCD Alliance. A big round of applause for our panel, please.
Hello? Okay. Thank you so much for that, Richard. And I thought that was a really powerful, introduction to this panel. Daniel and Valerie giving us the truths about kidney disease. I like particularly what Daniel said about, the future. We don't need the kidney replacement therapies because the goal is really not to really need that because everyone's been preventing this from, having to have kidney disease in the first place. But I'm so excited for this panel because we're going to build on that and talk about how do we catch this early? How do we integrate this into, NCD programs, given the integration, talking about how hypertension and diabetes is actually a high risk factors for kidney disease. I do want to start with Dr. Bianca Hemmingsen. How does kidney care fit into existing NCD care strategies at the WHO? And what are the consequences of underdiagnosis and undertreatment of hypertension and diabetes on CKD globally?
Thanks a lot, and thanks a lot for inviting me to this panel and for making this event. As mentioned, my name is Bianca Hemmingsen, and I'm working in the World Health Organization. As mentioned by Valerie, when she was here at the floor, that undiagnosed diabetes and hypertension is a huge problem. And it's the main drivers for the increased burden of kidney disease. It is hypertension and diabetes. So we need to address diabetes and hypertension in primary health care to get it early. In the World Health Organization, we have different initiatives to improve early detection of diabetes and hypertension. We have the PEN package, which is a package of essential interventions in non-communicable diseases in primary healthcare settings. And we also have the HEARTS packages, and it provides very simple treatment algorithms as well as informing people who to test. Another important thing I want to emphasize now when this is a kidney event is that it also integrates assessment of kidney disease. It's an integrated part of this treatment protocol and follow-up protocol for the visits when a patient is coming in with diabetes. It is the regular checkups, and also there are algorithms for how to initiate the early treatment. So this is some of the ways we do by integrating the chronic kidney disease into the agenda. Thank you.
Does WHO have numbers at the moment in terms of how many people have kidney disease at the moment?
We don't have any World Health Organization statistic on that, unfortunately.
No, but I think that that's really important as well to raise awareness about how important this is.
Yeah, it is a huge problem, and it's a huge prevalence, increasing prevalence, and increasing premature mortality. But beside of that, as also mentioned at the earlier panelist, it's also increasing burden for people with the condition and the healthcare system. It's very important that we get it caught early on.
It's true. It's true. Dr. Anna, from the perspective of family doctors or GPs, what are some of the main barriers to integrating comprehensive kidney care into primary healthcare systems, especially in low and middle income countries?
Thank you and good morning. Thank you for the invitation. Very happy to represent the global network of family doctors. 500,000 globally, member organizations in all regions. So we are there where you are. Okay, to your question, I will not go into the particularities of the different conditions, but take a system perspective. If we look at primary health care in low resource settings, the services are usually defined by disease. They are vertical programs, often and reproductive health, diabetes, hypertension, vaccination programs. We know them. We know they are often life-saving. But what is missing, and most where it is most needed, is the multidisciplinary primary healthcare team, preferably with a generalist doctor as part of the team. Because integration, and that is what I heard, I have good news for patients to say that family medicine is actually has that on offer. Your ABCD is what we are doing. To Valerie as well, to try and empower through promoting undergraduate and postgraduate curricula in generalism. Because what we, in our everyday work, experience, family doctors, is that if you fragment the approach to NCDs, you lose some patients and you give care, most care, sometimes, not always, to those who are not in the biggest needs. So it is also the individual tailoring which we have on offer and which is missing when we don't integrate the vertical programs with the continuity of care. So I can elaborate on that if you want me to, but that will be my first response to what you're saying, because family medicine is not easily understood. I mean, we understand what a nephrologist is doing, dealing with kidney health. We understand what a gynecologist is doing or an eye specialist. But our specialty has another kind of approach. And as we talked about before the session, Valerie, we can often, and you spoke about the algorithms. Sometimes the algorithms for the different diseases can be counteracting each other in the same patient. You need to know the patient, the medical history, the context, the resources, the level of literacy, and how far you actually can go. I mean, we can't change patients' behavior. We can try and help them change their behavior. It's about social determinants of health, and family doctors have ears to the ground and the ability to integrate these things. So now a lot of messages in this, but the main barrier is the vertical programs and lack of integration and the generalist doctor, which can take the whole responsibility also with the mandate of the doctor of integrating the primary care needs of a patient.
What are some solutions, do you think, to address that?
I think training, because if you look at also the primary care teams, if we keep to low resource settings, I'm privileged to come from a high resourced context with a with a very solid primary care foundation, but that is not the case around the world. I mean, that's the exception. I think training the personnel, because it's not realistic to have family doctors on all primary care teams around the world. We're not there. But the principle, and the principle could be also implemented in the training of other health personnel in the importance of the continuous and comprehensive care, right? To integrate, to be also train health personnel in what I would call clinical courage. You take the responsibility for your patient, even if he or she doesn't fit into your boxes, right? So training in the value base of primary care, that would be something. And we have examples also from low-income countries where this is implemented in training programs, and it has impact.
Interesting to hear that. Well, Alison, considering the broader context of NCD prevention and control, how does the NCD Alliance approach the issue of kidney disease, and what are some of the integrated strategies that you're promoting?
Thank you. So just to say, the NCD Alliance, we're an alliance of over 400 members around the world, including national and regional NCD alliances. So we're very much the civil society voice in this space. And I with some trepidation, given the WHO says they don't have figures, we do use some figures which are quite shocking about chronic kidney disease. So the sheer numbers, the people affected, there's around 850 million people worldwide. That's 1 in 10 people affected by chronic kidney disease. Lack of access to treatment means that 5 million people die from lack of access to the treatments to chronic kidney disease each year, which is more than AIDS and TB combined. And that's due largely to the fact that people living with chronic kidney disease don't know they have it until it's diagnosed very late, and when they need then access to the expensive treatments of dialysis or transplant. And it's a disease that's on the rise, sadly. It's projected to move from being the 10th to the 5th leading cause of death globally by 2040. So it's a really significant issue. And it's no doubt that it's a public health crisis. And when it comes to chronic kidney disease and the NCD Alliance, it's a chronic non-communicable disease, and it's very much part of the family of NCDs. The WHO talks about the big 5 NCDs of cancer, diabetes, heart disease, and respiratory disease, and mental health. But obviously, kidney disease is very much part of that broader agenda of NCDs. And as we've heard already, it's absolutely intimately connected in with hypertension and diabetes. So dealing with NCDs means dealing with chronic kidney disease. And we've also heard really articulately from Valerie and Anna already about the importance of primary prevention and secondary prevention of actual early diagnosis and screening. And particularly, we should also talk about the preventative measures as well around reducing people's exposure to the big risk factors of tobacco, alcohol, unhealthy diets, and lack of physical activity. And these aren't all to do with individual choice and lifestyle. There's a whole environment that's being developed in the way we live today that governments can play an active role in to try and reduce people's exposure to the risk factors that lead to hypertension and diabetes and chronic kidney disease.
NCDs are quite neglected in global health, right? Like right now, there's a huge focus on infectious diseases, pandemics. How do you think we can get policymakers? I know we have some in the room, but are also already, I think, champions on this, and even global health funders to recognize this as a priority.
Well, they say when you're trying to influence policymakers, you need arguments for the heart, the head, and the wallet. And we've heard a bit of both today already. And speaking to the heart, it was great to hear the voices of people with lived experience at the beginning. And I think Daniel spoke very eloquently to this about speaking the truth to power about the challenges. So I think it's really important that we have that voice and the sheer numbers and people recognizing the suffering that goes with chronic kidney disease. And placing that suffering, not just in everyday life, but people being more vulnerable to health emergencies like the pandemic. The estimates are between 60 to 90% of the people who died from the pandemic had pre-existing non-communicable diseases. People living in humanitarian settings, around 300 million people in the world today are in need of humanitarian aid. So if you think of those figures, these are people who are being displaced, disrupted. They don't have access to diagnosis. They don't have access to their hypertension drugs, to their diabetes medication, and so on. So we really need to put people living with NCDs, including chronic kidney disease, at the heart of our preparation and response to emergencies and crisis, because it's at the heart of the human suffering.
I want to go back to Dr. Anna. Daniel earlier was talking about out of pocket costs, right? And there's whole dimension of social determinants of health here. In some places, especially for low income families, right? When they feel something, the first thing they think of is not about going to the hospital and have themselves checked, because they would think, this is going to cost me, right? Maybe this is just a simple cough. I don't have to get checked. Maybe I felt something like a pain in my breast, but I will have to check because it goes away. So how do we address that? Getting people to actually have themselves checked. Maybe for hypertension, maybe for diabetes, so we can avoid getting to the whole scenario of people having to do dialysis and even transplantation.
You were passing just to one of our advocacy messages for the time being, and I was thinking about it when you spoke, because we are speaking medical care here, but we cannot speak NCD care without also speaking about social care. So what we've seen, not least through the pandemic, is the divide between health and social care has increased. And it goes without saying that it's no use in monitoring a person's blood glucose levels if he has no money to buy food to himself or his family. The same, and it is related, and that's in a way a non-communicable disease, which is not called that, and that is family violence. I mean, which also actually is relevant for what we're discussing here. Patching up the wounds of a battered woman without offering her safe shelter relates again to people now living in crisis and horrible conditions. And we don't have to name the countries we're speaking about. We know very well what's going on right now. So I think this is where, and this is a responsibility family doctors feel that they will try and mend that gap between health and social care. But again, the siloed services in countries is an obstacle there. So how to solve it? If you ask me, and what I tell our members when I'm traveling around the world is, at least you have to report to your politicians and policymakers, because family doctors have ears to the ground. They see things happening before it is captured in research. Research takes time, and it's about yesterday. So not to say that we can solve it and that we are the heroes of the world and can solve everything, but to utilize that potential of ears to the ground, and also to make sure that these services speak with each other and teach each other about the epidemiology they experience, is then back to training and dialogue.
With the increasing number of people getting on dialysis, getting on transplant. And I know Daniel talked about transplant earlier, but in a lot of places in my country, for instance, in the Philippines, it's not easy to get a transplant, right? And it's created this sort of, I wouldn't say sort of, let's say, black market in a sense, because people are kind of like selling their kidneys because they know someone actually needs it. Can we talk? But when there's an increased number of people on dialysis, that has an impact on health systems, right? Can we talk a little bit about cost, the cost of prevention versus cost of treatment? Alison, do you want to start? Yeah, go ahead.
Jumping to it. I mean, this is. I'll try and make it short. Norwegian register-based study published 3 years ago, looking at 4 million patients and their doctors. It showed that with continuity of care, level of hospital admissions, use of out-of-hour services, and mortality was reduced in association with the length of the continuity of the patient-doctor relationship. When the relationship had lasted for more than 15 years, these occurrences were reduced with 30%. 30% from all causes of death. This is, of course, not possible just to say transfer this and just do this, because there can be a lot of confounders. You can ask, this is possible in a stable country with a small population. Under different conditions, it will be much more difficult. And who are able to stay in stable relationships? It's not only about the doctor, a lot of things, but it's worthwhile, and it is cost beneficial. Back to your question. I mean, primary care is cost effective and it's effective on health outcomes. We know that.
You want to jump in that, Alison, and maybe Dr. Bianca?
Very quickly, I talked about arguments for the heart, the head, and the wallet, and I spoke more about the heart, but the wallet ones are really important for policymakers. We know that we can't treat our way out of the NCD tsunami. The sheer cost that comes from late diagnosis and the types of treatment that then requires, whether it's dialysis and transplants or chemotherapy and heart transplants, these are huge costs. So it's really important to get that argument across. And we see examples of governments who are doing that well. I was at an event yesterday. The Kenyan government was talking about the investment they're making through their universal health coverage effort in community health workers, delivering screening on blood sugar and blood pressure at the community level, because they know if they can catch people early and manage treatment early, they're going to save on both the human life cost and the healthcare cost.
It's super interesting. Doctor, can you maybe jump in?
Yeah.
Are we seeing the same sort of how much are these kinds of interventions happening on the ground in different countries, or is that just an exception, or just a few countries doing this?
Like on the ground, just to echo, there's no doubt that prevention and early detection is significantly more cost effective than delaying. And I also think that's the case that needs to be raised among policymakers as well, to make this a priority, the NCD agenda in general. Very few conditions. I cannot really come up with any condition in the NCD area where the energy to start treatment can pay off. It always ends up being more costly. And even though we have treatment protocols and we have different packages, what it comes to is the healthcare system, as mentioned by you. It's very important that you have a strong primary healthcare in all settings, but especially as well in low-income settings. It's much more cost-effective, and they meet the patient as the first step. So they are the one that can do the important early detection and the important early intervention. So it's really key to strengthen the primary healthcare. Surprisingly, we can say, even though we have mentioned the cost of the diagnostic tools to diagnose kidney disease, it's still not widely available. So I think there are several factors that needs to be addressed in order to increase the early detection. Awareness is one thing, but also strengthen like the procurement mechanism and also the political will to prioritize NCDs.
Can you talk about it? Because Alison was talking about, in Kenya, if I got it correctly, they're bringing that screening down to the community level. How many do we see that a lot more in low and middle income countries, or that's an exception?
It really varies. I'll say it's not easy. There are so many middle income countries to say that's how it's done. It really varies from country to countries. But in general, I will say when we do diabetes programs, they are always integrated in the general NCD program. So we have hypertension and chronic kidney disease. For example, now we have 2 programs in Ghana and Uganda where testing for chronic kidney disease is, of course, a part of this diabetes program. So you need to integrate it when we do. Even though I'm the diabetes focal point, I'm asked to do a diabetes program. It has to be broad and include all cross-cutting NCDs. As you mentioned, we cannot have the silos. We need to have the broad perspective for all NCDs.
Well, I want to open this up for Q&A. Sorry. But first, I'd like to recognize the presence here of Dr. Cordon Cruz, Minister of Public Health and Social Assistance of Guatemala. Minister, maybe do you want to provide some remarks and a question to the panel if you have?
Thank you so much. Yes, I will say I was here almost in the same room 10 years ago, and I was attending another session. And I just saw the NCD title of another session. And I never realized that I would be here 10 years after dealing with NCD issues in our region. And unfortunately, Guatemala is probably one of the countries where kidney disease is affecting the most. And all the issues that you were mentioning here, hypertension, diabetes. So what we are calling the 3 epidemics going on at the same time. And on top of that, how we are going to deal with the issue that even in this assembly, we are not getting an agreement what we need to do for the next pandemic. So the burden definitely will continue. I will say that it is extremely important that we address not just the issue of the new drugs that will be available, but all the legal issues that transplant also represents. So I will say that in our case, we have a national law for transplants now. We are developing the program. We will have certainly some protocols in place, but I am thinking that we need to also address this issue politically. So we were just discussing this morning that the Regional Council of Health Ministers of Central America, which includes Panama and Dominican Republic, we should be releasing a draft for our solution, declaring that the kidney disease is a chronic disease, should be included in the list of chronic diseases. So my question for the panel will be, okay, if we do something like that, how from this side, WHO can also help to support that request. Thank you.
Dr. Banke, do you want to start with that?
Thanks a lot. I'm so privileged that in 2021, we had the diabetes resolution. So that was endorsed by member states. And I have to say, it really does something when you have a resolution. It shows political wills and commitments, and you have an agreement with the member states, but it also requires the World Health Organization to do some commitments and to do some work. Regarding the role of the World Health Organization, actually, if resolution is proposed, the World Health Organization is like hands off. It's member states who decides if this will be endorsed. So just to put it a bit like in context, I will not be able to say endorse this because it's not our mandate to do it. But that being said, I'll say I can see for the diabetes agenda what a resolution has done for driving it, and also to have the political will, and also funding as well has come since the resolution, of course.
Maybe others? Yes, Dr. Anna.
Yeah, maybe this is beside the point, but it's not. I come to think about, because you spoke about community engagement, and that is important. And to my experiences, and I'm also thinking, look at us sitting here. Where do we come from? Who do we represent? If we're speaking about low-resourced contexts, our people are different from us. And we think we are in a bit in the illusion, if we only do the right thing, we will change. It is important also for this to be a bottom-up thing. So to engage the communities is more than just telling them, but it's also to ask, what does this mean to you? Like my African colleague, Jane, the regional Wonka African president, told me that to tell my patients that you have hypertension it doesn't exist anything you can't get rid of. How do you get rid of it? You can't. Now I'm speaking communication, how to communicate and explain. So the cultural context, to take that into consideration, I think it's extremely important, and that has to be done on the ground and not by missionaries coming there. I think that's a very important point. During the pandemic in Australia, I heard when we had our World Conference in Australia last year, there was a presentation by an Aboriginal professor of Aboriginal medicine. They left to the Aboriginals to do the campaigns during the pandemic. And they have usually very bad health outcomes. They were very well in the outcomes of the pandemic because their own people took care of the prevention, the screening, the testing, and promoting vaccination. So just from the side, we need to remember this.
Alison, do you want to bring, that's an interesting one. The minister was saying about draft resolution at the WHA.
I definitely think that's an important way that we get work out of WHO, but we also need money to follow to support that around the world. So you need a resolution and we need to apply budget. And to NCDs generally, I've heard the figure that only 5% of the WHO budget goes on NCDs. Is that enough? We don't know, but it doesn't sound like it. So that's part of it. The other thing to say is it's important not for us, when we look forward to, there's going to be the 4th UN high-level meeting on NCDs next year. This is a real opportunity for governments to renew their political commitment, but not only to make commitments but actually show that they're acting on those commitments, and for governments that are champions to step forward and say what they're doing in their countries and call on others to do more. But in that, I think it's really important to look at the fact that, multimorbidity is now much more the norm than it was. This isn't about vertical disease programs. We need to have an integrated approach to universal health coverage with a real focus on primary health care and be people-centered, and looking at, the way people present is not disease by disease, and to have a much more integrated approach. So for me, NCDs are very much part of delivering universal health coverage, and we can't have universal health coverage without dealing with chronic disease, including kidney disease.
Mm-hmm. Well, Minister, we're looking forward to how that draft resolution would unfold this week or in the future, WHA. Thank you so much for that. Any other questions from our esteemed audience? Yes, please.
Hi, everyone. My name's Jude. I work for IQVIA in their global health team. And I just had a question, sort of diffusely for the panel, about the role of the private sector locally in like delivery of NCD programs more broadly, because we know there's some really great work that's gone on supply chain, you know, that these huge markups of supply chain efficiencies, laboratory equipment maintenance to make sure you don't get potassiums that aren't hemolyzed, you know, training, all of these kinds of things. And I was just wondering whether the panel had any thoughts on kind of overcoming those barriers to help those be implemented more widely, because at the moment it just feels like there's really great pockets that then aren't being expanded. Just any thoughts would be really interesting.
Would anyone want to jump in on that?
I could do a short intervention, but also welcome to others. So yes, I'm aware. NCD Alliance is a member of the Coalition of Access to Medicines and Healthcare Products. And that brings together a range of organizations, including a number of pharma companies. So I'm aware of the great work that's being done in really developing in-country approaches to improving supply chain, data tracking, and product packages. I think what we need is to really build on those pilot cases and get good evidence and tell good stories and do more sharing of what works across countries. There's going to be this international financing dialogue next month, hosted by the World Bank and WHO, to talk about financing for NCDs. And you know, I've heard Monique Fleder from the health team at the World Bank talking about joint learning networks, and it would be fascinating if there was much more of this bringing together of governments and other stakeholders to talk about places where it's really working, what was learned and what could be scaled up. So we actually build on, you know, good pilots, but actually deliver the scale up by learning from them.
Dr. Bianca, is there something you want to add to that?
I can add, when we do country implementation in headquarters, it's always in collaboration with the regional office and the country office and the ministers of health. So that's our partners when we do country implementation.
Any other? Yes, please.
I love to hear the conversation that you're having about connecting the verticals and actually then bringing this as an integrated approach. And across the disciplines, there's a role to play there in that education. I'm keen to hear your thoughts about how we can better mobilise that education from specialty care to primary care. How can we help better mobilise I think you said it was clinical courage, and how do we better educate on the new options that are available for that earlier diagnosis and hopefully prevention of that end-stage disease setting?
That's right, and I think that's very much for you.
Yeah. Going back to 2010, the Lancet Commission on the Healthcare Worker for the 21st Century had a very strong recommendation to meet the needs, not least coming with aging and the epidemic of NCDs. The healthcare workforce, 50% of the workforce should be trained for and in primary care, because it's one thing is to be told, another thing is to actually experience. So I think that is that's another challenge to politicians and policymakers to actually make sure that we train the personnel we need. But it's the opposite, which is happening, and also primary care is losing the budget games. Even if we know and we say and we agree that primary care is important. So, and that also relates to the question about private sector, because when I hear that word, I always wonder, okay, what do you mean? What part of the private sector? Do you mean in healthcare? Or do you mean pharmaceuticals? Like in my country, I can tell you every week and several times a week in my patient population, I have a demand for the new diabetes medicines used to reduce weight. In a prosperous country of Norway, where we know how we should live. I mean, we have strict regulations on alcohol, tobacco, etc. And we learn in school that we should exercise. How do we, so I always get a little bit reluctant when I hear the word private sector if it's not defined more precisely. But training early in school, in primary school, that would be my advice if I could decide. Thank you.
Any other questions? Yes, please.
Thank you. My name is Rose Kapungu, and I'm here in a personal capacity. I have had a lot to do with kidney patients where I come from back home in Zimbabwe. Currently, I'm working here in Geneva. Very, very interesting discussions and very good to hear from you all. My question or comment is around the more practical things that the international community can do to help kidney patients in low-income countries. What are the more practical things that, as a patient advocate, that I can do and other people can do with the support of the international community? I know I'm going to try and grab Daniel to just get some insights on what you have done in your capacity. But also I think I'd like to hear from the World Health Organization, so Alison as well, from an advocacy perspective, but as an international community, what can be done practically, and bearing in mind the dire economic situation that people face, the policies that are not strong in favor of patients, the health systems that are not particularly strong, and we're talking about strengthening primary health care. How can this be done in environments which are poorly resourced, not patient focused? There's so much that I could say, but I'll stop here.
Daniel, do you want to start briefly?
Yeah, of course, it's in low-income countries, the landscape is so different. But I think awareness can be done in the schools and universities, and you can go to directly with an agreement of the university to spread the awareness about chronic kidney disease. And the problem of the chronic kidney disease is always the diagnosis is too late. So we need to try to reach before the chronic kidney disease is developed. So I think until today, usually primary care are referring the patients to the nephrologist, and I'm always trying that the nephrologist reach primary care before, just to review the cases, just in doubt, that just to help them in the interconsultancy. So I think an agreement from hospitalizations and hospitals to the primary care is really important. Education and training in professionals and patients in the community, in the university and the schools, and of course just to have a memorandum of understanding of institutions and all the entities just in the kidney community. This is my advice. Of course, you need to adapt in every country with the healthcare system. Environment is so different. Maybe it's a universal coverage or not. There's an insurance reimbursement. So you need to adapt in your own country. But this is my advice about education and in the global awareness about chronic kidney disease.
Right, Dr. Bianca, do you want to jump in?
I can see I have to be super quick. I see the time is going minus now. Thanks a lot for your question and for your willingness to engage more. I think civil society are super crucial to raise the awareness. I talk from the diabetes field. I see the social society being very strong and have really raised a lot of awareness about diabetes and have a lot of good initiatives also to connect people with diabetes. And in this case, it would be chronic kidney disease. One thing that we really try to encourage is to include people with lived experience at the decision-making table. We do it ourselves for the diabetes agenda, where we have people with lived experience in our experts group, our guide guideline groups, and whenever we have the chance to ensure that the aspect of lived experience is included. But I'll say what you can do on the ground in the specific country you're in. It will be awareness raising. Also to emphasize the importance of early detection of kidney disease and share the stories. Thank you.
Thank you so much. I'm afraid we don't have much time, but I'm sure if you have any other questions, the panelists will be willing to address that. Thank you again so much.
Thank you so much, Jenny. A big thank you to all of our speakers, Dr. Valerie Lakes, Daniel Gallego, Dr. Bianca Hemmingson, Dr. Anna Stavdal, and Alison Cox, as well as to our moderators, Ali Blunt and Jenny Lee Ravello, for guiding us through those complex issues today. And I would echo Jenny's call for us to continue this conversation. Hopefully it's not 10 years minister before we really move the needle on progress on this issue. But thank you very much for your intervention as well today. I'd also like to extend our gratitude to Charu Malik from ISN and all of her team. They've been excellent co-hosts here today, as well as to our supporting partners, AstraZeneca, Boehringer Ingelheim and Lilly, and Novartis, for really helping us to power our journalism here at WHA 77. So a big thank you. Last but not least, a big thanks to you, our audience here in Geneva, and of course to everyone watching along online around the world. Stay tuned for our ecosystem event, How AI Can Enhance Health Service Delivery at the Last Mile. That's coming up in around 30 minutes time at 10:30 a.m. In partnership with Medtronic Labs. Following that, stand by for day 2 of our Devex checkup at WHA 77, where we'll be kicking off with a session on resilient health systems. That's from 12:30 p.m. CEST. So from myself and the Devex team, thank you and see you again soon. All the best.